Yeah, I can share.
Okay,
One second.
great. All right. Okay. Terrific. So we're going to try and stay on our 5-minute boundaries if we can. Well, we have to if we're going to make it through. Okay. So off we go.
Sorry, my mic wasn't working.
Okay.
Hi, my name is Nicolette, and this is my partner Andrea. And today we will be going over our project, which is the impact of MRI quality on automated myocardial strain quantification across cardiovascular diseases. Our main goal is to evaluate MRI degradation and the effect that it has on deep learning-based myocardial strain quantification. So first, we wanted to go over some background of our project, and to start, we want to discuss how cardiac MRIs are used to assess ventricular structure and myocardial mechanics. So high image quality of these MRIs, as you guys might know, are important for cardiovascular disease diagnosis. So in this project, we are focusing on two main cardiovascular diseases to analyze. The first is hypertrophic cardiomyopathy, which is when the heart walls thicken and make it harder for the heart to pump blood. And the second would be dilated cardiomyopathy, which is when the ventricles enlarge and weaken. So prior studies have shown that deep learning segmentation are insensitive to image quality, which can affect myocardial strain quantification. So this reduced image quality can decrease your segmentation precision or introduce variability in wall thickness and strain measurements. So the main causes of these image quality issues are typically due to motion artifacts, including cardiac and respiratory, or patient movement, which can be more difficult for pediatrics or elderly patients. So currently, to minimize degradation in MRI scans, there are a few methods that are introduced. The first is patients might ask to maybe ask to hold their breath, which can be difficult, or deep learning noise filters are applied. So for our project, we wanted to discuss three specific aims. The first aim would be to establish baseline automated myocardial wall thickness and strain measurements from end-diastolic and end-systolic cardiac images. The second is to simulate reduced MRI image quality using Gaussian noise and motion blur. And the third and final is to quantify effects of image degradation on the precision and accuracy of myocardial wall thickness and strain measurements.
So for the methods of AIM-1, we are going to use the Automatic Cardiac Diagnosis Challenge Dataset, or also known as ACDC, that has seen MRI images for multiple patient groups. And we're choosing to use the normal patient group as our baseline, and then HCM and DCM as the diseased group, since these diseases
ICD is a gold standard for
heavily
diagnosing
affect.
coronary artery disease or artery disease.
Hello. Someone else is seems to have been sharing the screen or talking. So everybody, if you're
I
not
can say stop.
okay, great. If you're not presenting, you can put your computer on mute. Would be great.
Um, yeah, so these diseased groups heavily affect the wall thicknesses, and we'll be using a pre-trained LV segmentation model that was available on the ACDC Heart Project website, and it uses a UNet segmentation. And with the endocardium and epicardium boundaries that they outline, the wall thickness at end diastole and end systole will be measured. And using this equation below is how we will find the strain. So for AIM-2, this is where we're going to simulate signal to noise reduction, as well as cardiac motion artifacts. So we'll be doing that by applying not Gaussian noise at different levels, low, medium, and high, and then the same for motion blur. And from there, we'll apply the LV segmentation again and retake the measurements. And then the whole point of AIM-3 is to be able to determine how robust the deep learning segmentation model is by comparing the baseline versus degraded image using the DICE score method. And then we'll also use the absolute error, precision, and accuracy to quantify the deviation between the baseline image and the degraded image for wall thickness, and if the degraded image increases, variability as well. So for our outcomes, we are thinking that we'll see that the myocardial wall thickness and strain measurement accuracy decreases as image degradation increases. Also that the DCM may be more sensitive to image degradation than HCM, as the thinner myocardial walls increase proportionality errors with any boundary shifts during the segmentation. So this is shown in figure one, just an example of how we're assuming that the normal patient images will have a lower absolute error later through the degradation amount that's added, and then HCM and DCM. And then we are also looking to see that deep learning LV segmentation models will not be as robust as degradation increases. And this figure is just an example of adding Gaussian noise that we've done on MATLAB. You can kind of see that this is for low noise added to a normal patient. And these are our references. Thank you. I think you're muted.
Thank you. That's great. One question, quick question. You probably want to rethink whether or not your heart failure data errors will go up faster than your normal, because normal hearts move faster than sick hearts. So there's a balance there. Sometimes the heart is very stiff and it doesn't move much. It's easy to find.
Yeah.
So just think about
Point.
that a little bit, and that's great. Okay,
Okay. Thank
that's a
you.
great
Thank
start.
you.
Thank you. Let's go to team number two, and that's Evan.
Hi, give me a second to share my screen.
Sure.
That all visible?
Yeah, I can see it.
All right. Um, Hi, so this project is titled The Effect of LG MRI Image Quality on the Quantification of Left Atrial Fibrosis for AF Ablation Planning, and I'm investigating how MRI image quality affects the reliability of left atrial fibrosis quantification, which is used in planning atrial fibrillation ablation procedures. And overall, the goal is to understand how image degradation impacts the consistency of fibrosis measurements derived from MRI. So some background, atrial fibrillation is the most common sustained cardiac arrhythmia, and one of the key structural contributors is fibrosis or scarring in the left atrium. An LG MRI or late gadolinium enhancement MRI is a technique that is used to visualize this fibrosis, and in this method, a gadolinium-based contrast agent is injected into the bloodstream, and this contrast accumulates differently in normal versus scarred tissue, and fibrotic areas retain the contrast longer, causing them to appear brighter on the MRI images. And this allows clinicians to non-invasively visualize areas of scarring in the heart and can help guide treatment decisions such as catheter ablation. However, accurately quantifying fibrosis is challenging for several reasons. The left atrial wall is very thin, often only a few millimeters, so even small imaging errors can significantly affect measurements. And in addition, MRI has limited spatial resolution, and image quality is further degraded by motion from both cardiac and respiratory activity, as well as just general noise. And because of these limitations, fibrosis quantification may not be fully consistent across different image qualities. And to study this, I have three specific aims. First, I'll simulate MRI image quality degradation. Second, I'll evaluate how these degradations affect fibrosis visualization and segmentation performance. And third, I'll quantify how these changes impact measurement reliability. And going more into detail about the specific methodology, I'll start by selecting a representative LG MRI images from published datasets to serve as a baseline reference. There's a challenge of the Mikai Stockholm Left Atrial Segmentation Challenge that provides a dataset that I'm able to work off of. I'll then simulate different types of image quality degradation in MATLAB, and this includes adding Gaussian noise to simulate reduced signal to noise ratio, or applying motion blur to represent cardiac and respiratory motion, and downsampling the image to simulate reduced spatial resolution and partial volume effects. And after generating these degraded images, I'll analyze how fibrosis visibility and segmentation change under different conditions. And I'll use threshold-based segmentation to estimate fibrotic regions and edge detection methods to evaluate boundary clarity. And finally, I'll perform quantitative analysis using several metrics, and these include contrast to noise ratio, fibrosis area percentage, edge sharpness, and segmentation overlap similarity. And these will help me quantify how stable fibrosis measurements remain as image quality decreases. And as for my expected results, I expect that decreasing the image quality reduce the reliability of fibrosis quantification. Visually, as you can see in my small sketch on the side over here, The edge maps from the degraded images should show weaker and less continuous boundaries compared to the original image, and the noise is expected to introduce false edges while motion blur will reduce the boundary sharpness and make fibrosis regions less distinct. And quantitatively, I expect trends such as decreasing segmentation overlap accuracy as noise increases and decreasing edge sharpness with increasing blur. And overall, the expected outcome is that MRI image quality has a direct and measurable quantification used in AF ablation planning. That's my presentation.
All
Thank you.
right. Terrific. So I would couple of things when you're doing your degradation, if you can do it the way it would happen in real life, like going into K-space to do some degradation over there and bring it back, you should do that. Two, on your metrics for performance, you should make sure that one of those metrics is close to what is used in the literature to quantify the severity of the fibrosis. Okay. So
Gotcha.
they
Sounds
they use
good.
something as like total area or some they'll use something, but you want to put that in there. I don't know, you might already have it.
Gotcha. All right.
Okay,
I'll look into that.
fantastic. All right, so the next is team three with Tiani and Yinji and Xiaotong.
Can you see the screen?
Yes,
Okay.
fantastic.
Everyone. We are the team 3. Today, our project is about beam hardening artifacts in contrast-enhanced cardiac CT. And first, let's introduce the clinical problem behind this project. The cardiac CT perfusion imaging relies on iodinated contrast enhancement to visualize blood flow and myocardial perfusion. However, when the iodine concentration in the left ventricular blood pool becomes very high, it can cause beam hardening artifacts. As shown in the image on the right, the darkened region in the myocardial tissue is not necessarily a true perfusion defect. Instead, it may result from the high attenuation contrast in the left ventricular cavity. As a result, this artifact can potentially lead to the false positive interpretation during myocardial perfusion assessment. And in other words, the resulting beam hardening can produce apparent myocardial hyperenhancement adjacent to the left ventricular blood pool. Therefore, our research aim is to quantify this, how increasing left ventricular iodine concentration affects these beam hardening induced false positive perfusion defects.
Building on the clinical problem we just saw, our approach is to simulate this directly in a computational phantom. First, we will construct a simplified concentric LV geometry using parameters from Kitagawa's paper, myocardium at 130 HU, LV blood pool around 600 HU, and we sweep the iodine concentration from 0 to 24 milligrams of iodine per milliliter. This will cover the full clinical range used in cardiac CT perfusion protocols. Then we will proceed to step 2 to apply a polychromatic attenuation forward model and without any beam hardening correction and compute the artifact-induced edge drop in the myocardium at each concentration step. This let us isolate exactly how much of the signal change is coming from beam hardening alone, not from the true ischemia. Step 3, we will set a classification threshold if the artifact-induced drop exceeds 15 to 20 HU, which is a clinically reported range for a true perfusion defect. Then we will flag that as a false positive, and our output is a false positive rate as a function of iodine concentration, which you will see on the next slide.
So as Amy has introduced on the previous slides, for the expected outcomes, as is shown in the left side, it is actually a literature example of the phenomenon we are trying to model. So at the higher iodine dose, the myocardium shows more apparent darkening, while at a lower dose, it appears to be reduced shadowing. So this is the real imagined motivation in in our simulation. And on the right top side, we have simplified that actual model into a toy LV myocardium phantom. So our idea is that the low LV IDM should give us a mostly uniform myocardium, while the higher LV IDM may create a bin hardening shadow that looks similar to a perfusion defect. And the third panel is just a reference for what a true defect might look like. And for the curve side, our main measurement is that the edge hue drop between a normal reference region and the shadowed region. We will plot the HU drop as a LV iodine concentration increases. And once the drop passes a simplified 15 to 20 HU threshold, we treat it as a possible false positive defect. And then if we add noise and repeats the simulation, we can estimate how the false positive risk changes with iodine concentration. So overall, we expect a higher iodine concentration to be increased the HU drop and raise the chance of a false positive fusion defect.
Okay, that's great. I'm going to have to stop there because we're over time. So,
Yes.
looks like a good project. I can give you a little bit of advice, but I'll do that later. I'll email you some later. Okay.
Okay.
But that's good. That's a cool project, and it's an important problem. So now we're on to team four. Um, and sorry. So it's Matthew and Sardor. Can you take the screen?
Yes, 1 second. Okay, can everybody
Yes.
see the presentation? Okay, great. All right, good morning, everybody. My name is Sardor, and with my partner, Matthew Callahan, we'll be presenting a project on evaluating how CT's partial volume effect impacts characterization of lipid-rich coronary plaques using Raman spectroscopy as the chemical reference standard. So the main question is we're just trying to answer whether CT systematically misclassifies lipid-rich plaques because multiple tissue types are averaged together within the same voxel. So plaque characterization is clinically important because vulnerable lipid-rich plaques are strongly associated with heart attacks, and CT imaging doesn't always accurately identify them. One major reason is the partial volume effect. So when a CT voxel contains multiple tissue types like lipids, calcium, and fibrous tissue, the scanner can sometimes average these signals together into a single attenuation value. And so that can blur the plaque boundaries and obscure smaller lipid-rich regions. To address that limitation, we're comparing CT imaging against Raman spectroscopy, which is a non-destructive optical technique that identifies tissue composition using molecular vibrations. And so instead of just measuring attenuation like CT, Raman can also provide us a chemical fingerprint of the plaque itself. And so by comparing these two methods, we hope to better understand where CT fails and where Raman data can improve plaque classification. So now I'm going to pass it on to Matthew.
Hi, you can hear me okay, right?
Yes.
Yeah.
Okay, great. So moving on to our proposed approach in papers, first off, we want to go ahead and establish like a strong profile for exactly what type of information you can extract from either platform and how they can complement or not complement one another. So ideally, we can develop a nice table that can show us what the actual plaque components are represented in either modality, and then start to mix and match from there. We'd also be looking to create perhaps a partial volume model. That way we can actually interpret and mess with the volume considerations here. And then we'd also look to then quantify the CT failure modes by using the Raman-derived molecular composition spectra as a prior to then start to assess and reinterpret those CT voxels that might be a little bit odd or suspicious or not properly classified. And then move forward into perhaps getting like a firm qualified lipid fraction estimation error to validate either the improved method versus the prior method.
Great. So okay, quick question. The Raman data will be simulated data as well?
So that's kind of where we're having a little bit of like circumstantial outcomes here, because I think most ideally we'd use like a real data set, because the
Yeah.
Raman is going to be outstandingly difficult to simulate. And honestly, like the level of chemical complexity is going to be almost necessary for this study.
Okay, so that's going to be the outline of this is great, but the thing that I'm isn't clear to me is like how we get the ramen data. But that's something we'll have to cross that bridge, I guess. But yeah, I mean, even without the ramen data, you can get pretty far along specific aim 2 and 3 in terms of where it falls down for CT and partial volume, right? So you'll have
You,
some good outcome even if you don't have this gold standard ramen
so
data.
you could build out the entire computational framework for it, but whether or not it works might be kind
Okay,
of coming down to that.
cool. Well, that's really cool. I'm looking forward to that.
Yep.
Okay, thanks. So we're on team 5. Wei and Nick, Hannah and Katie.
Oh, hi, could you hear me?
Yes.
Oh, I think you can start it.
Yes. Yes, please start.
So I can start it. Okay. So like, hi, we're group 5 and I'm Wei.
I'm Hannah.
I'm Katie.
I'm Nick.
And our group project is Carla. We stand for Cardiac Agentic Reconstruction and Learning Architecture. Carla is an auditable multi-agent pipeline for 40-flow MRI, and we take root case-based data and run it through reconstruction, segmentation, and dynamic analysis. After that, we perform a deterministic physics check to validate the output. The goal is not just to generate the clinical numbers, but to turn them into a traceable report that clinicians can trust.
Slide, yes. Current cardiovascular imaging workflows face three major challenges. So first, multi-agent systems are difficult to coordinate reliably. Unclear task decomposition, inconsistent communication between agents, and limited verification to confirm whether outputs are correct before passing them downstream can lead to unreliable results. And secondly, most medical AI tools operate as black boxes, so they generate outputs without transparent validation or intermediate checks, which makes it difficult for clinicians to audit or trust the results. And lastly, 4D flow MRI analysis is a complex multi-stage pipeline. Error introduced during reconstruction, segmentation, or hemodynamics analysis can slightly propagate through the pipeline, and existing tools typically handle each stage independently without automated verification between them. So to address LLM coordination failure, we built a multi-agent pipeline where every decision is logged to a machine-readable audit trail. And to address the black box problem, we implemented deterministic physics verifier independent of the LLM, which applies physics checks to every case. And to address pipeline error compounding, we follow a three-version roadmap: detect error with the verifier in V1, recover through an agent retry loop in V2, and learn from successful correction in V3. And V1 delivers the measured detection rates that make the rest possible.
And for methodology, our architecture splits decisions between LLM agents and the Python skills. The three agents that we have is the planner, critique, and coordinators. They handle the coordinations for the job. And for skills that we applied, it's the reconstruction, segmentation, hemodynamic, and physics verifier. They are assigned with standard imaging skills that are hard-coded. Later on, we can introduce them into some current models. Every decision is logged based on skills, and we are currently testing them on OpenCloud with Tianwen 3.6, and all the data that we use is the OSU MR 40 flow data.
So then these are the examples of the broader outputs we expect from Carla. So at the pipeline level, the system should produce reconstructed 40 flow MRA data vessel segmentation masks, hemodynamic metrics verifier results, and a complete decision trace. So what's shown here is an early example using the OSU-MR clinical data. And we can see here that the mask is imperfect because it captures more than just the aorta, which could lead to incorrect downstream metrics. And that is called out by the pipeline from the rightmost figure. It shows that there is divergence fails and flux conservation fails. So V1 gives us detection and auditability. And in version 2, that same failure signal becomes actionable and we can proceed to allow the agent to retry, revise the plan, and recover.
And here's our references. Sorry, I think you are muted.
Okay, thanks. Yeah, that looks pretty cool. It looks pretty ambitious, and I'm really looking forward to seeing it run in real time. Will you demo it like in real time? Put up a case and we'll see what it does.
Yeah, sure. I think we can pre-record a video of the pipeline,
Yeah,
or
that'd be great.
it takes time to like processing a recon and then
Yeah.
do the analyze. Yes.
That'll be fun to watch. Yeah, so I look forward to that video.
Sure.
All right, so team 6 is next, Xinhuan and Yan Tong. Biological age. Here we go.
Yeah, let me share my screen. Yeah. Can I guys see the screen?
Yes.
Okay.
Okay, good morning. We are group 6, and our topic is predicting cardiac biological age from MRI imaging using deep learning. And the main idea is that the chronological age does not fully describe the cardiovascular health. So two people can have the same age, but their hearts may look younger or older. So the cardiac MRI is very useful because it captures structure and functional information, such as the chamber size, ejection fraction. So our goal is to explore whether MRI-derived cardiac information can be used to estimate the cardiac biological age and whether this age gap can reflect some cardiovascular risk. Okay, so the background is what problem are we addressing? So clinical age is easy to measure, but biological cardiac aging may be better captured by imaging-derived structure and function. So there are lots of questions which need to be resolved, such as clinical problem, imaging opportunity, and modeling question, and validation need. So we have 3 aims. First, review which MRI feature are age sensitive. And the second, describe a deep learning or feature-based model for age prediction. Third, discuss how the cardiac age gap could be validated using risk factors. And our research question is, can MRI-derived information be used to predict the biological age, and can the age gap reflect the cardiovascular risk?
Right. So our workflow starts with cardiac MRI cinema images, and there are 2 possible modeling paths. The first is a feature-based path. We use segmentation to extract cardiac phenotypes, such as ventricular volume, ejection fraction, myocardial mass, strain, and aortic stiffness. Then these features are used to train an age prediction model. The second is an image-based deep learning path, where a CNN could learn aging-related patterns directly from MRI images. The model output is predicted cardiac age. Then we define the cardiac age gap as the predicted cardiac age minus chronological age. And for evaluation, we would check whether predicted age tracks real age using metrics, like mean, absolute error, or correlation. Then we will test whether a positive age gap is associated with cardiovascular risk factors. And for the final presentation, we expect to show 3 types of outcomes. First, an age prediction plot comparing predicted cardiac age with actual chronological age. And second, a clear explanation of the cardiac age gap. A positive gap means the heart appears older than expected, while a negative gap means it appears younger. Third, clinical validation plots showing whether the age gap is higher in people with cardiovascular risk factors, such as hypertension, diabetes, higher cholesterol, or CVD. And our expected conclusion is that cardiac MRI may support an interpretable biomarker of cardiac aging, but its usefulness depends on model validation, image quality, and whether the age gap adds information beyond chronological age. Yeah, and that's all. Thanks.
Terrific. Thanks. And I would spend a little time when you bring it back and produce the results, like what does cardiac age actually mean? Is it just a mapping to risk? Is it an accumulation of features that now give you a new looking age versus the person's chronological age, right? So you probably want to spend a slide. You didn't have to do it here. This is looking good, but on just defining that, right?
Yeah, that's good. Thanks.
Yeah, it'll be interesting to see.
Mhm.
What happens if your ventricle looks young but your aorta looks old? Okay, so next is group 7, Nadine and Karina and Angeline.
Okay, so just starting off with a little background. Angeline, can you go to the next slide? Thank you. So chronic coronary artery disease can lead to two types of dysfunctional heart tissue. One is hibernating myocardium and the other is infarcted myocardium. A hibernating myocardium is still alive but has reduced function due to low blood flow, meaning it can recover if blood flow is restored. But infarcted myocardium is permanently scarred and non-viable, so treatment is usually just limited to medical therapy. Correctly distinguishing between these two conditions is critical because it directly affects treatment decisions and patient outcomes. Currently, myocardial visibility is commonly evaluated using rubidium-82 PET imaging. Rubidium-82 behaves similarly to potassium, so active heart cells will take it up naturally through the sodium-potassium transport mechanism. And once inside the cell, the tracer uptake will also reflect mitochondrial membrane integrity and overall cellular viability. As it decays, it will emit positrons that generate gamma rays detected by the PET scanner to create a 3D perfusion image. The main engineering limitation with this is rubidium's 82's long positron range. So the positrons can travel about 2 to 17 millimeters before annihilation, which can cause image blurring and reduce spatial resolution. So this is important because the myocardial wall is actually only 8 to 12 millimeters thick, so the signal can spill into the surrounding tissue, making the viable myocardium appear thinner or non-viable. In infarcted tissue, membrane integrity and mitochondrial function are severely disrupted, causing a major reduction in the rubidium-82 uptake. So as a result, the hibernating tissue may be underestimated or even completely missed, which can prevent patients from receiving potentially life-saving revascularization procedures.
So we plan to implement a model that's validated by the literature to the left of the slide. And so this is mainly to isolate the tracer binding from flow using ODEs. And so by solving these ODEs to the right of the slide using MATLAB, we can actually separate the perfusion from the metabolic signals using K1 and K2, which allows us to pinpoint the hibernating tissue where cells could remain viable despite the restricted blood flow. And so in MATLAB, we plan to generate a synthetic arterial input function to moderate tracer bolus across 3 physiological states: normal, hibernating, and scar tissue. So our code will account for the kinetics and noise present in rubidium-82. We'll demonstrate that these effects can cause signals to overlap in rubidium-82, while the superior resolution and mitochondrial binding with F18 can create a much wider diagnostic window for identification of salvageable myocardium.
So through our experimental simulation approach, we'll be able to answer the question, can the higher extraction fraction and lower positron energy of the F18 labeled tracers improve the detection and distinction of the myocardial tissue viability compared to the traditional RB82? And we expect that our F18 labeled agents will allow for improved spatial resolution, signal quality, and signal-to-noise ratio. In the top right, we see that the F18 has a lower positron range, so it produces a signal using shorter range of distance to limit blurriness, which is important in detecting these small regions and sharpening boundaries between scar and viable tissue. It will help improve image clarity because of this higher contrast and less noise, allowing detection of the smaller regions. And when discussing the kinetics of the tracer, it's broken down into one compartment model where the tracer flows in through the blood and gets trapped in the mitochondria of live cells and myocardial tissue with a higher extraction fraction than the RB82, and then leaves the tissue depending on the tissue health. In the lower right is what we'd expect to see, where viable tissue retains the tracer longer because of the mitochondrial binding with a higher sustained time activity curve versus scar tissue, which we see on the lower end with a low uptake and rapid washout, so a low flat curve. And the significance of this is being able to differentiate between viable hibernating tissue and non-viable scar tissue, so that way physicians can determine whether patients will benefit from revascularization surgery or not. Thank you.
That's terrific. Yeah, I think you guys have it pretty well nailed in terms of the underlying physics. So I look forward to seeing what the actual quantitative results are for the simulation. Good work. Okay, we're going to team 8, Mingyu and Tingner and Ricardo.
Hey, can you hear us?
Yes.
All right. So this is team 8. Our topic is photo counting CT or PCCT against energy integrating detector CT or DIT-CT. Sorry, I'm narrowing this bar here. So for our background, while CCTA is the gold standard for diagnosing coronary artery disease, current DIT-CT technology is often limited by beam hardening artifacts, which raises misdiagnosis of stenosis severity. So our hypothesis is that because PCCT, misclicked. PCCT energy beams enable more chromatic reconstruction. The resulting images will be mathematically resistant to this beam hardening effects, fundamentally improving signal stability. And to demonstrate this, our project follows 3 specific ends. First, we are characterizing the physical differences between the 2 detector types. Second, we are developing a Python-based simulation of X-ray attenuation to model high contrast scenario. Finally, we will quantify the signal-to-noise ratio and artifact reduction to validate PCCT's superiority. And ultimately, we expect to show that PCCT provides higher quantitative accuracy in tissue characterization, leading to fewer technical errors and more reliable cardiovascular diagnosis.
So here's our project's methodology. And first, we will do the literature review. We'll see the physical differences between EIED and PCCT to identify the key performance metrics. And then we will do Python simulation to model polychromatic X-ray attenuation and beam hardening through high density media for both detector types. And third, we will compare these 2 technologies. We will reconstruct signals to compare EID style broad spectrum integration and PCCT multi-energy beam thresholding to generate synthetic sinograms for each detector model. And last, we will do quantitative analysis. We will quantify artifact reduction by measuring Hu uniformity and calculate SNR improvements in myocardium and lumen ROIs to validate our hypothesis.
Here come the estimated outcomes we expect from this project. On the left side, the panel A shows a sketch of predicted SNR values across 3 clinical scenarios. In the soft tissue, the EID-CT and the PCCT perform similarly around 18 and 20 decibels, because beam hardening is minimal when there are no high-density structures nearby. However, the gap widens dramatically in the more challenging cases. For a calcified vessel, the EID-CT drops to just 8.2 decibel, while PCCT maintains 17.8 decibel. And in a contrast-filled LV chamber, the most clinically demanding scenario, the EIT-CT falls to only 6 decibel, whereas PCCT holds at 16.4 decibel. This pattern confirms our hypothesis that PCCT's advantage is specifically largest where beam hardening is most severe. On the right side, the panel B illustrates what this means visually. The EIT-CT image shows a dark streak between the two high-density objects. This is the classic beam hardening shadow artifact that obscures the tissue signal in between. And the PCCT reconstruction on the right eliminates this entirely, producing a uniform signal throughout the phantom. And next page is our references.
All right, terrific. So, well, I make sure this goes for everybody for all your simulations and your Python code and stuff like that. Save that your final version of that, and you're going to hand it in with the project so we can see the details of how you do all this modeling. Okay, that looks great. That looks ambitious and will be quite useful. All right, so team 9 is Natalia and Magna. Terrific.
Yeah, perfect. Okay. Hi, everyone. I'm Meghna, and my other teammate's Natalia. And our project is titled Minimum Perfusion CT Frames for LAA Blood Transport Quantification. So our overall goal for the project is to determine the minimum number of 4D CT perfusion frames needed to accurately quantify blood transport parameters in the left atrial appendage, or LAA for short, while significantly reducing the radiation exposure to patients. So current clinical protocols use 26 CT frames collected over approximately 40 to 60 seconds. So while it does provide the detailed information we need, it's also a relatively high radiation dose. So we're just aiming to see if we can preserve the clinical data while reducing the number of frames so that it's within a clinically acceptable dose of radiation for the patients. So just a quick background, atrial fibrillation patients have approximately a 5-fold risk of stroke increased and over a 90% embryolic thrombi originating in the left atrial appendage. So dynamic perfusion CT imaging can help quantify the blood stasis in the LAA before clot formation. So the current 26 frame acquisition protocol carries a non-trivial radiation burden for now, but the more important question we're trying to ask is how many frames are necessary to maintain the reliable measurements? So our first aim is to quantify how the mean absolute error, or MAE, and to also take the 95% confidence interval for the transport parameters and see how they degrade as the number of frames decrease. The second aim that we're trying to see is also to compare two frame selection strategies. So uniform space sampling versus peak concentrated sampling, where the frames are more collected around the contrast enhancement peak. And finally, we're also going to try and see if we can identify the minimum number of frames that keep all transport parameters within a clinically acceptable range in at least 95% of subjects, and then translate that into an estimated radiation dose reduction for the most part.
And then to achieve these aims, we will begin with the original data set that was provided. First, we will fit a gamma variant model to all 26 frames for each subject in order to establish a ground truth set of transport parameters. These parameters include maximum enhancement, peak arrival time, and residence time. Next, we will systematically subsample the data set at different frame counts, specifically 3, 5, 9, 14, and the original 26 frames. And then we will refit the model for each condition. We will repeat this process using two sampling schemes, uniformly spaced sampling and peak concentrated sampling. This will allow us to compare which strategy preserves parameter accuracy more effectively at lower frame counts. Afterward, we calculate the mean absolute error relative to the ground truth and perform Bland-Altman analysis at the recommended frame count to evaluate agreement between reduced frame and full frame measurements. Finally, we will estimate the corresponding radiation dose reduction using scanner parameters from the GE Revolution CT system. And to strengthen the robustness of the study, we will also plan to repeat the analysis using both a gamma variant model and a two-compartment washout model to ensure our conclusions are not dependent on a single modeling approach. And for expected outcomes, we expect to observe that parameter error decreases as the number of frames increases. One likely trend is that very low frame counts, such as 3 or 5 frames, may produce large variability and inaccurate estimates, while intermediate frame counts, potentially around 9 to 14 frames, may still preserve clinically acceptable accuracy. We also expect peak concentrated sampling to outperform uniform sampling because capturing more data around the contrast enhancement peak should better preserve physiologically important transport dynamics. And these graphs shown here illustrate the expected relationship between frame count and parameter error, as well as examples of how artifact-prone or undersampled reconstructions may compare with correct or optimized reconstructions. Overall, we hope this work can contribute towards safer cardiac CT imaging protocols by substantially reducing radiation dose while maintaining clinically meaningful transport quantification.
Cool. It'll be a very important number to know, like what N is, and also what the minimum dose or the dose that is required to keep those parameters useful. All right, cool. I'll send you an email also on some of the back end stuff about evaluating what's useful for patients.
Okay, thank you.
Thank you so much.
Okay. Next is Team 10, and that's Eli and Yehing.
All right. Good morning, everybody. I think there we go. Okay, I think I'm there. You able to see my PowerPoint?
Yes.
Okay. All right. So good morning, everybody. So Yihang and I are working on this project together, and we're going to be looking at photon counting CT and comparing that to the conventional CT for detecting calcified coronary stenosis. And our overall goal is to sort of quantitatively compare these two using phantom imaging, and we're going to try to evaluate like their spatial resolution, their Hounsfield unit accuracy, and sort of look at their calcium blooming artifacts, which is sort of an issue with conventional CT. Okay, so a little bit of background. So conventional CT has, although it's like the commonly used imaging technique, it has limited spatial resolution when it comes to imaging calcified vessels. That can result in in it producing like blooming artifacts that can actually inaccurately sort of inaccurately diagnose stenosis severity and affect the visibility of the vessel lumens. And so recently, photon counting has been like a newly introduced method that offers better spatial resolution and hopefully improve coronary calcium imaging. So a few of our specific aims, we want to compare the spatial resolution with these techniques and look at like the image sharpness between conventional CT and photon counting using some of the provided phantom DICOM data sets. We're still trying to see if perhaps we can find patient scans, but that's really difficult. I think I was able to do a little bit of digging, and Stanford may have a data set, but it's behind a paywall, and so and they don't really have they don't grant access to anybody. So we're still trying to see if perhaps.
Sorry, I think you're still on slide 1. If you're meant to move it, it's still on the
Oh,
title.
really? Oh,
Yes.
let me see. Maybe it's just a sharing issue. Let me stop share and then I'll reshare it. Oh, okay. That's unfortunate. I don't know what's going on with my Zoom.
So it was sharing correctly, but it just, as Diana said, we were on slide 1 for that whole thing.
Yeah,
Oh, okay,
we can
okay.
see it.
Maybe I'll try
We see it
this.
now.
Okay.
We see it now, yeah.
Okay, sweet. Okay, so that was our specific aim. Our second one is to sort of evaluate the differences in calcium blooming in like reconstructed kernels within these two different scanners, and then lastly kind of assess their noise characteristics using some sort of MATLAB program that we're still trying to develop. Okay.
Yeah, so for our methodology, we will use phantom DICOM datasets acquired from both photon counting CT and conventional CT systems. First, we will review the images in horals to identify mesh slices, calcium inserts, lumen regions, and whole fountain structures so that comparisons are made at the same locations. Next, we will perform quantitative analysis in MATLAB by extracting line profiles and defining regions of interest, or ROIs. We will evaluate several image quality metrics, including spatial resolution using PSF and FWHM, calcium blooming artifacts using HU-based measurements, and HU accuracy and image noise using mean HU values and standard deviation within the selected ROIs. Overall, our goal is to quantitatively compare PCCT and conventional CT under different reconstruction kernels and imaging conditions. And yeah, this slide shows a possible outcome of our project by comparing conventional CT with photon counting CT. On the left, the PCCT phantom image resolve finer line pair structures than conventional CT, indicating higher spatial resolution. On the right, the PCCT image appears sharper and preserves more fine details, while the conventional CT image looks more blurred. So high spatial resolution may help reduce calcium blooming artifacts and improve the visualization of the vessel lumen in heavily calcified arteries. This is one of the main motivation of our project, where we plan to quantitatively compare resolution, blooming effects, and ensure accuracy between PCCT and conventional CT. Thanks.
Terrific. Okay, so yeah, just remember that you have to, if you're going to only compare the difference between PCCT and energy integrating, you want everything else to be set the same, like the kernels and the reconstruction and all that stuff. You don't want that to overwhelm what the difference is between the detectors. So if you're looking at detector resolution. Okay,
Yeah,
so
thank you.
Thank you.
yeah, that's great. So let's go to team 11, Catherine and Tanya.
Sorry, I couldn't unmute. Can everybody see my screen?
Yes.
Okay, perfect. I just want to hide the controls really fast. Are the Zoom controls on the screen? I'm sorry.
No,
Okay,
only
cool.
you see those. We don't see those.
Okay, perfect.
Yeah.
Okay, so oh my goodness, I'm so sorry. I can't move it.
It's looking good on this end.
Okay,
You can just use it the way it is.
Okay, so my name is Catherine, and my partner Tanya and I's goal of our project is to investigate whether faster, reduced slice cardiac MRI workflows can preserve accurate ejection fraction estimate. So ejection fraction, or EF, is a key clinical metric used to evaluate cardiac function and guide diagnosis, prognosis, and treatment planning in cardiovascular disease. Cardiac MRI, or CMR, is considered the gold standard for EF measurement because it provides accurate and reproducible three-dimensional assessment of the left ventricle. In the standard workflow, EF is calculated from approximately 8 to 12 contiguous short-axis sine slices. At end diastole and end systole, the ventricular cavity is segmented in each slice, and ventricular volume is estimated using Simpson's disk summation method. Although this approach is highly accurate, it is also relatively time-intensive because it requires analysis across the full short-axis stack. This raises the question of whether reduced short-axis sampling could preserve clinically meaningful EF estimates while decreasing analysis burden. However, reducing the number of slices may also introduce volumetric estimation error. So the goal of our project is to quantitatively evaluate the trade-off between reduced short-axis sampling and EF accuracy. Specifically, we aim to quantify how EF error changes as the number of short-axis slices is reduced. We then plan to compare different slice selection strategies and evaluate performance across different disease groups. And finally, we will evaluate whether hybrid short-axis and long-axis approaches may improve reduced slice EF estimation.
So in order to achieve these aims, we plan on using the MNMs2 challenge dataset, which consists of data from 360 patients across both healthy phenotypes and a variety of cardiac pathologies. This data was acquired from 3 clinical centers using 3 different scanner models and contains both long axis and short axis images that are annotated by expert clinicians with the contour for the left ventricle cavity, as well as labels for the end diastolic and end systolic frames. So our anticipated workflow is as follows. First, for setup, we will annotate each of the image slices with the area of the left ventricle contour, then apply disk summation method to calculate the ground truth ejection fractions for each patient. Once the setup is complete, we'll move to the experimental aspect. So we'll select slice subsets from each stack, recalculate the volume and ejection fraction, and then quantify error compared to the ground truth. We anticipate that by the end of this project, we'll have a model that is able to systematically select subsets of the image stacks, both uniformly. So for example, every other stack or every other image or every 3 images, as well as anatomically. So for example, only using basal, mid-ventricle, and apex images. We also anticipate that this model will be able to automatically calculate the ejection fraction, accounting for increased interslice gaps, and then graph comparisons of the error versus the number of slices used.
So this graph illustrates the relationship we expect to observe between slice reduction and EF estimation accuracy. The blue line represents the ground truth ejection fraction calculated from the full short axis stack, while the red curve represents the reduced slice EF estimate. We expect that as more short axis slices are removed, the reduced slice estimate will deviate further from the ground truth, particularly at more aggressive levels of slice reduction. We also hypothesize that hybrid short axis and long axis approaches may help preserve EF accuracy at lower slice counts by supplementing sparse short axis coverage with additional geometric information. And here are our references.
All right. Thanks. I'll probably send you an email with some ideas about the project, specifically about the shapes of the different hearts and stuff like that. Terrific. So we're moving to team 12, Sakshi, and Flossie.
Hi, can you see my slide?
Yes, we can.
Okay. Hi everyone, I'm Flossie.
Hi, I'm Sakshi.
And our project is titled CNN-based automated myocardial ischemia detection for improved CAD diagnosis using SPEC MPI. The goal of this project is to automate the detection of myocardial ischemia from SPEC MPI images using CNN. We hope this can support faster and more accurate coronary artery disease diagnosis. Our approach is to use stress and rest SPEC MPI images as input, process them through a custom convolutional neural network, and then apply GradCam explainability to highlight the regions that may be contributing to ischemic predictions. So our model is designed to do 2 things. First, classify the scan into disease-relevant categories, and second, provide visual explanations that make the predictions more clinically interpretable.
So the reason we selected this topic is because coronary artery disease remains one of the leading causes of death worldwide, and one of its earliest warning signs is myocardial ischemia, where reduced blood flow prevents the heart from getting enough oxygen. And detecting this early is critical for preventing serious cardiac events. SPECT MPI is already widely used as a non-invasive tool for diagnosing ischemia, but has important limitations. This is where AI can help. Deep learning models, especially CNNs, are effective at recognizing complex imaging patterns that may not be obvious through manual review. Our first aim is to develop a CNN model that can classify scans into normal, ischemic, or infected cases. Second, we'll evaluate its diagnostic performance using clinically meaningful metrics like sensitivity and specificity. Finally, we'll use GradCam explainability to highlight the regions influencing the model's decision, making the predictions transparent and clinically interpretable. Our overall approach is to build an AI model to detect CAD from cardiac SPECT MPI images, and we'll be using stress and rest myocardial perfusion images because comparing blood flow under stress versus rest helps us identify whether a patient has normal perfusion, reversible ischemia, or permanent damage from infection. Before training the model, the images will be cleaned and standardized through pre-processing steps like resizing, normalization, and focusing on the heart region. We'll also use data augmentation to create more variation in the dataset and prevent overfitting. And we'll then train a CNN-based deep learning model, which would be an RGB CNN model, from which we could use to recognize patterns in these images and then classify into three diagnostic groups. We'll then test settings like dropout, patch size, and network structure to find the best performing model. And then finally, we'll evaluate how well the model performs using metrics like accuracy and sensitivity and GradCam to visualize which parts of the heart influence the model's decision.
Our expected deliverables include a 3-class CNN classifier, optimized hyperparameters, ROC curve analysis, GradCam visualizations, and a final summary of diagnostic performance. On the right side, we show examples of how we may present our model evaluation. The table shows the type of performance matrix we would report for a base CNN model, such as accuracy, recall, precision, F1 score, and Matthews correlation coefficient. It also shows how we could compare different dense node settings while keeping dropout fixed at 0.2. Below that, we show example evaluation plots, including an ROC curve, a precision recall curve, and a score distribution plot. These would help us evaluate how well the model separates healthy cases from coronary artery disease cases and how reliable the predictions are across different thresholds. And overall, we expect this project to support more consistent spec and PI interpretation, provide visual explanations for model predictions, and help identify myocardial regions associated with ischemia or infarction. And here are references, and thank you.
That's great. Well, good luck in training that thing up, and make sure you set aside a good independent testing set so that it doesn't just memorize who's sick. That's one of the big challenges. Okay, that looks great. Team 13, Samene.
Yep, sharing my screen. All right, do you see my screen?
Yes.
Sounds good. Hello, everyone. My name is Sameno Dusambat. My project is aimed at creating a software tool that would help us to early detect perineural tumor spread from the MRI image. So to go into the background quickly, so PNTS, perineural tumor spread, is kind of a major pathway where tumors from the primary site, specifically head and neck tumors, spread deep into the brain, following the paths of nerves, cranial nerves. This is kind of difficult to find early because they are small compared to kind of typical tumor size. Because of this, there is subjective interpretation by radiologists. So the goal, or the specific milestone of my project, is to automate cranial nerve segmentation and quantify the symmetry of nerve on 2 different sides of brain, and then train the deep learning model for early perineural tumor detection. So approach is kind of feed MRI data, segment MRI data. From that, identify different radiomics features such as thickness of nerve, perimeter of nerve, and train deep learning model. And eventually, once it attains sufficient level of accuracy, that would be used by radiologists for decision support. For the data, I'm considering to use data from Radiopedia, brain meta share from Stanford University, and for the long-term project, so we are applying to access data from UCSD Department of Radiology. From the methods, kind of using again the symmetry and the asymmetry of nerves into different sets of brain, extracting features, and we'll be using Jupyter Notebook and deep learning algorithms such as UNet. Expected outcome eventually to have a software that would be able to predict the asymmetry of nerves on 2 different sides of brain. From that, it would be predicted that there is a potential of having perineal meltwater spread or not. We also expect to create a scoring system where the scoring would be assigned to the symmetry or asymmetry of nerve on two different sides of brain, and based on that, the severity or the probability of having perineal meltwater spread would be predicted. Some of the metrics that we'll be using for scoring is perimeter of nerve area thickness and mean intensity of MRI image. Thank you.
Well, that's really cool. Is there a large literature on existing methods for cranial nerve segmentation? Like, are you confident that that's not going to be a big sticking point?
That's actually the big sticking point. So there's not big literature. I think kind of groundwork should be done on that aspect.
On that aspect, okay.
Yeah.
That makes sense. I mean, that's probably a big enough thing for the project, right?
Yeah. If I
you
can achieve a aim1, that should suffice, I guess, for this project.
I think if you can come up with a way to confirm that these cranial nerve segmentations are correct, it would be a huge thing, right?
Okay, thank you.
Okay, great.
I'll share my screen.
Good luck.
Thank you.
Matthew and Tan and Yumu, we're on team 14 now. Coronary motion.
Okay, let me share my screen first.
Wait a minute, I've got to allow you there. I don't want to have to do that, but
Can you see it?
it says it's still loading. Now we're back to the people page. There we go.
Okay. Good morning. We're team 14, and our project is a simulation study of motion artifacts, motion effect on detectability and CAC scoring. The goal is to determine how cardiac motion affects the detectability and CAC scoring of microcalcifications in CT. Our overall approach is to use a MATLAB-based CT simulation pipeline with digital coronary phantom for calcifications of different sizes and densities. Microcalcification is a coronary artery marker of coronary artery disease, which is important lesion to look at during breast cancer screening. And the detection of calcifications are clinically important because they may help identify early symptoms of disease. And the problem is motion blurry in CT images could affect calcium detectability, resulting in inaccuracy of diagnosis and potential treatment. Our main goal is to quantify the cardiac motion velocity effects on detectability index, SNR, and the CAC scoring. We'll also find an approximation of velocity threshold where the borderline lesions are lost from scoring, and examine if cardiac motion are affect the two potential and radiation dose for visibility of microcalcifications by human observers.
All right, so to tackle this aim, our method will rely on a simulation study using MATLAB. So first, we will generate a 2D digital phantom with a specified calcification size and density. We then apply a cardiac motion profile on the phantom to simulate the motion artifacts. We then apply a CT profile onto that recreated images. We will also apply multiple velocity profile for the coronary motion in order to visualize how it's changed the calcification detectability. Afterward, we will measure the peak Hounsfield unit, the area with over 130 Hounsfield unit, CAC score, and detectability D prime for the calcification. And based on the multiple motion velocity, we also want to determine at which point the calcification will become undetectable. And next slide.
And for the estimated outcomes, we'll show the detectability index, which is an index to quantify how a human can visually identify the calcifications. We show the detectability index versus a coronary motion velocity to show the motion affect the visibility of the small calcifications. And beside the detectability, we will also compute SNR and CAC score for comparison, and so that we can connect the physics result and along with the clinical scoring result. And the plot here shows an estimate result of the detectability index. And as the velocity increase, we will expect a stronger motion blur, which lower the calcium signal and decrease D prime. And based on the Rose criterion, when the D prime drop below 5, the object is considered below the reliable visibility threshold. Yeah, and that's it.
Okay, that's great. I think, are you going to get a set of curves for different sizes, I guess, right?
Yes, we will have multiple sized for simulations.
Got it. Okay, that's great. I'm interested to see what your estimate is for the size, that it disappears and humans can't see it anymore.
Yeah, thank you.
Cool. Okay, Nasheen, Dita, and Austin are up next.
Hey, hello. So our project is automatic detection of electrode and cardiac regions in heart imaging using segmentation models. So breaking that down, let's go to the next slide. You can see in this video that there's like very irregular arrhythmias, and electrodes are generally used for cardiac mapping. A lot of the questions that one asks would be like, is it possible to predict how the heart is going to respond to these electrodes? And there are a lot of wonderful models that are being built at the McWay lab that hope to do something like this. And the one of the biggest problems in doing something like this is being able to know exactly where the electrode positions are. And it's a very manual and labor intensive process to physically go in and choose the electrodes, as you can see in the lower image. So our goal is to see if we can predict, if we can create a model of, based on us getting these different scans, are we able to create a 3D model of where the electrodes are placed? And these are our specific aims, which I'll not say for the sake of read out for the sake of time, but that is our overall goal: create a 3D rendering of the electrode placement with respect to the overall heart.
Okay, so our approach combines supervised machine learning and classical computer vision to handle both labeled and unlabeled data. The dataset includes 17 patients with expert annotated ground truth and 286 raw scans. We extract lead centroids and normalize the coordinates to millimeters using affine transformations. We then test two complementary methods. First is machine learning. So we train regression models on extracted heart and lead features. For classical computer vision, we threshold bright metal voxels directly from raw CT scans, cluster them into candidate blobs, and then filter them by size and cardiac proximity. We also explore hybrid optimization, combining CNN predictions for geometric refinement and point net architectures for 3D point cloud processing. And finally, we evaluate everything, compare predicted centroids to ground truth using Euclidean distance and visual overlays. This dual approach strategy helps generalize to all the 286 patients and gives robustness.
So for our expected outcomes, this slide shows some of the models that look strong on training data but perform worse on honest training. The gap tells us that the models are learning something from the data, but overfitting to a small data set. The figure helps justify why cross-validation and simpler baselines are important, and also shows the feature engineering that showed more data are more likely needed. Here we narrowed the task to predict one distill lead target to see whether performance improves. The figure compares several models against a mean baseline, so it shows whether any method is actually useful. The feature bar helps show which feature groups contribute most to the prediction, as well as the scatter plot gives a visual check of how close predicted values are to the true positions. Thank you.
Okay, so it looks like you're about halfway there, right? You're sort of got a structure for how this thing is going to work, and now you're looking at performance, and it's not performing that well. Is that what I'm getting from that?
Yes, correct. We're the pre-processing of the data is pretty much solid. So we're still testing like computer vision or like machine learning wise.
Yeah.
That's what we've been doing.
Okay, cool. Yeah, this is not a trivial problem, I don't think. It's like it takes a human experience to get this right. So my guess is that it's going to take a few iterations and you'll discover something along the way. I'm not sure it will work, but you'll discover something.
Yes.
That's great. All right. Excited, especially if it works. It makes a huge impact. Okay, Jason is up next.
Hi everyone. Today my project proposal is titled Cardiac CT Assessment on LV Mechanics in Ischemic Cardiomyopathy. The main idea is to use cardiac CT not only as an anatomic imaging tool, but also as a way to evaluate left ventricular structure and mechanic in the setting of ischemic cardiomyopathy. The overall goal of this project is to evaluate how cardiac CT can be used to assess left ventricular structure and mechanics related changes that are relevant to ischemic cardiomyopathy. Ischemic cardiomyopathy clinical important because the coronary artery disease or myocardial infarction can lead to ischemia, LV dysfunction, and eventually ventricular remodeling. For the imaging side, I want to start with a demonstration workflow using OsiriX dataset, which includes 10-phase cardiac CT sequence. This let me show how systolic and diastolic phase can be reviewed. Then for the main plan analysis, I want to use the full multi-phase CT data to calculate EDV, ESV, ejection fraction, wall motion, wall thickening once all phases are available. The figure on the right summarizes the clinical pathway from CAD or infarction to LV dysfunction and remodeling and connect the pathway to CT-based analysis. The outstanding clinical problem is that the ischemic cardiomyopathy is not only about coronary narrowing. Coronary narrowing tells us about how blood supplies, but it does not fully describe how much the myocardium has been affected. Clinically, LV function and regional mechanics are also important because they help with the diagnosis, risk stratification, treatment planning, and follow-up. That's why this project focuses on measuring like the EDV, ESV, EF, regional wall motion, and wall thickening. This measurement can show whether the LV is dilated, whether systolic function is reduced, and whether specific region of the myocardium are contracting abnormally. For the specific aim, the first aim is to demonstrate the CT-based LV mechanics workflow using the OsiriX cardiac CT data. The second aim is to perform full multi-phase CT analysis after complete phase data obtained. The third aim is to compare the patient measurement with healthy referenced cardiac CT measurement so that abnormal remodeling and impaired contraction patterns can be identified. The first aim is in the future direction use to measure the CT data as label for machine learning and deep learning model that could make LV segmentation functional analysis faster and more reproducible. This slide shows how to plan methodology. The first step is loading the CT data, including OsiriX and 10-phase demonstration data. The second step is the phase selection. For the clinical mechanical measurement, we need to identify end distal and systolic. Systolic should correspond to the larger LV cavity volume, while the end systolic should correspond to the smallest LV cavity volume. The third step is the LV segmentation. I will segment the LV blood pool with the myocardium because the blood pool is needed for the EDV, ESV, and EF. what the myocardium is needed for the wall thickness and the wall thickening. The fourth step is metric calculations. And the image on the right, it shows how I already have to start with reviewing the phase image from OSIRIX and the structural phase with a phase 0 CT image, which help establish the workflow before the full analysis. For the expected outcomes, the expected outcome is a CT-based workflow that demonstrates phase selection, LV segmentation, clinical mechanics measurements. Once full phase data is available, I expect generate the patient level table include EDV, ESV, EF, wall motion, and wall thickening. The second outcome is comparison. I want to compare patient measurements with the healthy reference values to identify abnormal remodeling and impaired contractions. For ischemic cardiomyopathy, I will expect findings such as increased LV volumes, lower EF, abnormal regional wall motion, and reduced wall thickening. The final future outcome is the machine learning deep learning framework. If manual or semi-automatic measurements are created, they could later be used as the training and validation labels for automated LV segmentation and faster mechanics extractions. Here's my references. Thanks.
Okay, terrific. That's a big project. In terms of taking all that on in the next 2 weeks, but Godspeed, man. If you can do it, it will further sort of confirm, how AI is helping us move very, very fast. Okay.
Thank you.
Yeah. And we got one left. We're on team 17, Tom. And I'm sorry, I'm going to steal 5 minutes of your. So we're supposed to end class now, but if you can finish, if you have to go somewhere else, that's okay. But I'd really like to get through.
Yeah, sure. Hi, can you see my screen?
Yep.
I will try to finish this. I will try to finish it quick.
Okay.
So my project. Oh, sorry.
It's good. We see it perfectly here.
Okay, so my project is about the effect of cardiac motion on detectability on small target in CT. As we know, the cardiac motion will affect the image quality. And my objective is to quantify how cardiac motion affects the detectability and image quality of small calcified targets in cardiac CT. So this figure shows different level of cardiac motion of artifact in coronary CT. From the left to the right, you can see the image quality increase along with the decrease of the motion level. So my background is that cardiac motion will introduce motion blur and reduce image quality of CT imaging, and especially the small calcified target is sensitive to the motion. So the detectability can be quantified using detectability index. It measures how easily a target signal can be separated from the background noise. Higher the D prime, the calcified target is easier to detect. For my specific aims, first, I will simulate cardiac motion during CT acquisition and reconstructions. Second, I will evaluate how motion affects the detectability of small calcified targets. And third, I will quantify the motion-related changes in image quality using contrast, CNR, intensity profile, and apparent target size. As for my methodology, I have two versions because I'm struggling finding a suitable data set for my project. If I successfully find one, I will use the cardiac CT slice as the background. Then I will insert a small simulated calcified target around the coronary area. Then I will apply simulated cardiac motion during CT reconstructions with MetaLab. Finally, I will quantify detectability with contrast, CNR, and D prime. If I fail to find a suitable database, I will create a simple CT-like pattern in MATLAB. Here's the estimated outcomes. So after I insert a calcified target around the coronary area and apply the simulated motion, then contrast then recontrast with MATLAB, it should be looks like a bright spot on a dark background. And I will use a tool like ImageJ to analyze it and get the data I want. So suppose the CNR, the peak intensity, and the D prime supposed to decrease with the increase of motion level. Okay, thank you for listening. Here's my reference.
Okay. Well, it'll be interesting to see if you come up with the same answers and estimates for the size of something that disappears at a specific velocity.
Yeah.
As I guess it was Team 14, right?
Yeah, we have a
same thing.
similar
So
project.
we'll see we'll see the two estimates and see what happens. See if they come up.
Yeah, we'll see.
Yeah. Okay, everyone, thank you very much for putting the effort into those. They were great. And keep in touch by email in terms of updates with if you need some input. And there's a couple of questions that I've got down here that I'll email out and ask you about the project to further specify what's going on there.